Hello, hey guys, hey. This is the Trauma Study Guide Review Part 2. So this is the backside of this trauma study guide. I wanted to go over these just to make sure you're studying the right answers. So we went on a call to a patient who had a hip fracture and you're giving a medication list. What medications would make you worry? So if you think about this, if the patient falls on the hip, with any trauma, the one thing we worry about is bleeding. So a patient with a hip fracture, we're going to worry if they're on any blood thinners. So what drugs are blood thinners? We've got Coumadin. This is the most common. And it's generic, it's readily available. Most nursing home patients are on it. It's a pill. We also have heparin, which is very common. It's injectable. Don't forget aspirin is technically a blood thinner because it prevents platelet aggregation. And another popular one is Lovenox. This is a blood thinner that's injected in the subcutaneous tissue. But Coumadin is the most popular, most likely one you would see because it's a pill form, so it doesn't require a lot of nursing intervention. What is treatment intervention for bleeding? So number one is direct pressure. We do direct pressure with as few fingers as possible to put enough pressure on to stop the bleeding. If that doesn't work, next we do a tourniquet and we do shock treatment, which is supine, oxygen, high flow oxygen, and keep the patient warm, cover with a blanket, called ALS backup and transport. What are the signs of pericardial tamponade? This is Beck's triad. There's three things. You don't need to know that's called Beck's triad, but you need to know the three things, which is JVD, jugular venous distension, so the veins in the neck are bulging. JVD, muffled heart sounds, and they're muffled because there's blood in the pericardial sac surrounding the heart, and so when you're listening, you're hearing the lub-dub through the blood that's surrounding the heart, so it's muffled. So JVD, muffled heart sounds, and hypotension. Those are the three signs of pericardial tamponade. What are the signs of a pneumothorax? Okay, so a simple pneumothorax is we would have unequal breath sounds because a pneumothorax, remember, part of the lung has been collapsed from trauma or puncture, penetrating wound. So if the lung is collapsed, then we're only going to hear the inhalation and exhalation lung sounds of the healthy lung, not the collapsed lung. But we always monitor, and the patient may be short of breath, difficulty breathing, tachypneic. We always worry when we have a simple pneumothorax that we could create tension, and the tension could push the trachea and the heart away from the midline, and it would cause a obstructive shock where we're hypotensive, tachycardic, JVD. So unequal breath sounds on a simple, and we always monitor for a tension pneumothorax, which is obstructive shock. And trachea is deviated, and JVD. Okay, abdominal trauma. Make sure you know which side the liver is on and which side the spleen is on, because there's a couple of questions, and they're sort of related to your patient is stabbed in the right upper quadrant. What organ could hit, or the left? So the right upper quadrant is the liver, and the left upper quadrant is the spleen. Okay, what is the primary concern when you have a burn to the face? So here's the big one in all caps: airway, 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 airway. With facial trauma, we worry about airway, and with burns, we worry about airway, because if someone has burns on their face, that some kind of heat source has burned the skin on their face, then we worry that they have been inhaling superheated air, and it would burn the airway. It would cause swelling, difficulty breathing, and airway obstruction. So if we have any burns to the face, airway, airway, airway. And really good signs that the patient needs advanced airway management is if you see soot around the mouth, or singed hair in the nose, or if they're coughing up carbonaceous sputum. So if they're coughing up sputum that looks like it has like black or charcoal in it. What is our primary concern? If a patient jumps over, has a laceration from jumping over a rusty fence. So in all of the lacerations where the skin is punctured, we worry about infection. The skin protects our body from infection and heat and fluids, and so anytime there's a break, we got to worry about infection. What do we do with an amputated extremity? Okay, so we're going to put the extremity or the digit that has been amputated, put in a plastic bag, and we're going to float the bag on cool water, not ice. We don't want to damage the tissue, just in case reimplantation is possible. So not on ice, because ice can damage the tissue, and we don't want to put the actual digit or extremity into the water because that can damage the tissue. So we protect it in a plastic bag and we float it on cool water. What are the vital signs we expect with a patient who has a traumatic brain injury? So this is Cushing's reflex. Okay, so hypertension. So we're talking 200 over 100. So really high systolic and a normal to high diastolic. So hypertension, super, super high, like 200 systolic. Bradycardia. So our heart rate, we're looking like 40, 48. So really low heart rate. So super high blood pressure, really low heart rate. And then we have an abnormal breathing pattern. Okay, air under the skin gives you that crackly feeling that is subcutaneous emphysema. What kind of posturing do patients have when they have a severe head injury? So with the posturing that we're looking at is decerebrate and decorticate. Decerebrate is when the patient is flexed and the extremities are coming to the core. And a decorticate is this abnormal extension where the extremities are extended and kind of flexed out. So both of them are bad, and both of them are indicative of a severe head injury. But decorticate is slightly better than decerebrate. So the very worst is decerebrate. Is decerebrate posturing. Okay, when would we remove a knife that is lodged in the chest? If it interferes with CPR. So if you need to do chest compressions and it's in your way. So let's say you have a patient that's been stabbed and the knife has remained in the chest and it's in the 4th to 5th intercostal space, lateral to the sternum, right? Well, that's right next to where you need to place your hand. So that's going to be in the way. If you need to do chest compressions, you need to remove it. Otherwise, we leave objects, penetrating objects, we leave them where we find them. We stabilize them with bulky dressings, with gauze, and wrap it, and we stabilize it so that it doesn't keep moving and damaging the tissue, but we stabilize it and we transfer unless we have to do CPR and it interferes with CPR. And our Glasgow Coma score, the highest is a 15 when you get everything right. And the lowest you can get if you're dead is a 3. So you can't get lower than a 3. Okay, this is Trauma Study Guide Part 2, the backside. And thank you all. Hope you have a great day.